So I found this Chinese saying, and I hope it's fairly accurate, not do, not die. And that's very appropriate for groin pain in football, because groin pain is something that we associate with football players mainly. So we can tell all our athletes to stop playing, and we'll probably solve the problem. But as we love football, we know that we cannot do that. So they will continue playing, and they will have groin pain. So if we look over the last 15 seasons in the UEFA Champions League, we can see that football players have a fairly constant rate of about 1 injury per 1,000 hours of playing. So the incidence is high, and it remains high. Furthermore, on average, there's about 15 days of absence of playing, and that is also on a trend fairly constant through the last 15 seasons. So when Dr. Michel Duch in the keynote lecture talked about the football medicine revolution, we are unfortunately yet to see that within the field of groin pain in athletes. What I will go through is some of the advances that we've made over the time. But we have to first know that the assessment of groin pain relies more than in time loss injuries. So a study from Denmark in Copenhagen on sub-elite football, they asked players from 40 different clubs to recall the last season and whether they had groin pain. 50% of players actually said they had groin pain the last season. 30% of these had groin pain for more than 6 weeks. So a real big problem in football. But what we can see is that more than half actually didn't even miss a match. So they were playing with pain and continuing on. So we have to ask ourselves, how much is it affecting them and how much is it affecting the performance of our teams? In Oslo, they developed a more specific approach to capture these injuries, these overuse injuries, with a simple system with 4 questions asking the athletes to report back on their participation amount, their training volume, their level of performance, and whether they had any pain. We can get an overview of weekly prevalence of groin problems in general. They did that for groin pain specifically in football, and they grouped the different types of groin pain in 3 entities. So if there was no reduction in any level, it was considered no groin problems. If the players reported any kind of groin pain or any kind of groin pain that groin problems that caused pain, caused reduction in performance, or in their training volume or participation, it was considered a groin problem. And then a substantial problem would be a moderate to severe reduction in training volume or in performance. And we can see from these studies that the prevalence of groin pain, the weekly prevalence of groin pain, is very, very high. At least 1 in 5 players of your teams are likely to report a groin problem. And about 1 in 10 will be having a substantial groin problem. And this is even more so in periods with match congestions. So up to almost 1/3 of your players will have groin problems. And it's a bit less in females, about half, which is similar to what we see in time loss injuries as well. So imagine your team, and you have to pick 1/3 of these players who have groin problems. Does it then matter which of these players are having time loss injuries? And if they're limited in their performance, could that potentially affect your results of the whole competition? There are more to these injuries, and we can get a more detailed overview of these injuries. If you're familiar with the hip and groin outcome score, it's a more detailed questionnaire to ask about the groin pain in the players. It'll ask on 6 different subscales with pain, symptoms, activities of daily living, any functional limitations during sports, the participation level and the quality of life. And in the same study as I talked about before, the players were asked about these different items in the beginning of the season. And what you can see from the graphs over to the left, the players that have pain for more than 6 weeks, they were significantly limited in their function and had a considerable amount of pain in the beginning of season after the season break. So what we get from that is then groin pain will not just disappear over the course of a winter break or a summer break. So we have to act, we have to do something. There are different ways to prevent groin pain. There are several rehabilitation programs or prevention programs that have tried to be implemented, and these are often fairly extensive. And when we multiply all of these in a meta-analysis, we can see that it's a limited amount of reduction that we get on groin pain. So we have to do a bit better. We have the FIFA 11 Plus, which we know has great results across a number of injuries. But what we can see from the FIFA 11 Plus is that there's no hip adduction exercises. And this is something that we consider very important in groin pain. Adductor-related groin problems are the most prevalent form of groin pain in football players. About 2 out of 3 players will have adductor-related groin pain if they have groin pain. So, in Norway, did a study on the FIFA 11 Plus, adding a single exercise to the program. So they substituted the Nordic hamstring exercise with an exercise called the Copenhagen adduction exercise, which is an exercise where you have one player holding the leg of the other player, and then the player lifts his body up and down together with the leg, slow and control, in order to increase the strength and increase the capacity of the adductor muscles. And what we can see from an 8-week program is that the normal program did not gain any strength increases in eccentric adduction strength, but adding the Copenhagen adduction, you had a considerable increase in adductor strength. And that is only with one set of this exercise. This exercise, we've done a bit of research before as well. If you do it more, you will gain more improvements in strength. In an 8-week program where we perform 2 to 3 sets, a progressive protocol twice a week, increasing from 6 to 15 reps, we saw over 8 weeks a 36% average increase in eccentric adductor strength, something that we think is considerably related to the chance of having groin pain. So this was an interesting finding. So up in Oslo, they did an amazing RCT, so randomized controlled trial, where they used only one single exercise. So the players were grouped in 2 groups based on teams. So a number of teams just performed their normal training, and the other group of teams had one exercise that they needed to do. And you can see the progression here with only 2 to 3 sessions and only 1 set per side during the preseason, and then during the season, only once per week you had to do this exercise. And the players could choose which level they were on. If level 3, they were encouraged to do the original Copenhagen adduction exercise. If that was too hard, they could make it easier until they were ready to do the actual exercise. So they did that during the preseason, and we can see prior to the preseason, we monitored the prevalence of groin problems, and that was almost a third, again, that had these groin problems. Then they had an 8-week period, or 6 to 8 week period, where they performed this preseason training. And we can see the top line is the prevalence, the weekly prevalence of groin pain in the players who did not perform the exercise, where the lower line is over the season, the course of the season, the weekly prevalence of groin problems in the group that had performed the Copenhagen adduction exercise, so the adductor strengthening protocol. So that was a significant reduction, equivalent to 41% lower risk of having groin problems with one single exercise. When we're looking at the substantial problems, it was a bit less, so a little bit less effective in preventing and in reducing the risk of substantial groin problems, but similar to the majority of the studies which were released one single exercise. The next step is then, you have your players, you've performed a prevention program, you know there's still going to be players with problems. How are you going to detect these, and how are you going to detect these early? You can perform a simple test on a weekly basis, on a daily basis in the club, the Copenhagen 5-second squeeze test, where you just have one player, or your physiotherapist or doctor, putting the arm between the ankles of the player and asking him to push together as hard as possible. If he reports pain of 0 to 2, he's very likely not to have any functional limitations on the field. If he reports pain 3 to 5 on a numerical pain rating scale from 0 to 10, there will be a limitation in his function and his pain on the pitch as well. So it's something that you have to watch, potentially examine, and modify training or structure a rehabilitation program to make sure that he optimizes his performance. And if the player reports 6 out of 10 pain in that test, he probably has a considerable injury, and you should probably take him out because the chances that he has severe limitations in his function is considerable. So an easy test that just takes 5 seconds per player. If you have a little bit more resources, what you can do is you can start monitoring the strength. A simple squeeze test, as you can see down in the bottom, with a dynamometer to give you an estimate of the force output of the player. Also a very good test to perform. And then, as shown here in Australian junior football, you can see that these players had a reduction in strength before they actually had a time loss injury. So, when you see reductions in pain, you can consider that these players are fatigued and may be entering a period of considerable groin pain. So you can modify their training and act accordingly in order to keep the players on the pitch. What we have to remember is that the test that you use also matters. In players on a group level, we can see that isometric strength is usually not increased in players with groin pain, but when we're looking at eccentric strength, there's a considerable reduction in strength and force output in players with adductor medial groin pain. And this is also something that we can relate to the exercise that we showed before. Another thing that you have to remember is that preseason adduction strength is not a good option. You have to continue to monitor. We did a study in Astifar as part of the preseason screening for all the players, where we measured the eccentric adduction strength of all the players in the league. And here we can see we followed them through 2 seasons, and we can see which players had an injury and which players did not. And there's so much variability in the strength that you cannot detect the players that will potentially get an injury just based on your baseline strength testing. So that's very important. So if you choose to have strength as a potential risk factor for injury, it's something that you have to continue to monitor. Otherwise, it's probably not very useful. Another element that you need to consider is that groin injuries are a bit more complex than most other injuries. There are many different structures that can be involved. If we look at the adductor specifically, there are several different injury mechanisms which may cause pain. We did a study on acute adductor longus injuries, which is the most prevalent form of acute groin injuries in football. And we can see that there were 3 or 4 different injury situations that we could look closer at. There was a change in direction here, exemplified by the goalkeeper. Passing here, so not maximal kicking, but also maximal kicking drills. When the player is reaching for the ball, and a few cases where jumping was the cause of the acute adductor longus injury. And all these injuries have fairly similar positioning of the player. So we can see the hip going out to abduction, but also extension and external rotation, which are important components of the injury mechanism that really stretches the adductor longus muscle and puts load on the structure. And that can cause an acute injury, but it can also be the result of repetitive overload causing an adductor longus insertion problem.